Welcome, everybody. Archer, excellent, welcome. Lost, Vicky, Peacock, welcome. Arpat, Nikki, Assignment, Bella, welcome. Suspicious Bunch, Pacific Swells, welcome. I am Chicago DLS Inc. Nicole, welcome. I do one-on-one Naplex and MPJE tutoring. And we also are going to start group sessions soon. If you are interested, feel free to send me a direct message. If you have taken an assessment or have taken the Naplex before and want some feedback on a score report, feel free to also reach out through message. I'd be happy to provide you with some direction. Today we're going to be covering asthma. If you're new, save your questions. I will answer them all at the end. The resources I use for these presentations are RxPrep and Pass Naplex Now. Both are phenomenal resources. If you're doing questions and you feel like you are lacking in your prep, feel free to supplement. Using both is not necessary. Nicole, Melissa, welcome. We'll have practice questions at the end, and by no means are my presentations comprehensive. This is supposed to be a mini lesson, and then just to refresh you or reinforce that you're feeling prepared, depending on where you are on your journey. There will be a survey at the end. Please make sure you provide your feedback. It's used for improvement, and we appreciate it. Shout out to Suspicious Bunch and Pharma Turtles, the mods, for setting this up, and we will get started. Archer, Soma, welcome. So, background. Asthma is a reversible inflammatory disorder of the airways, and you will experience as a patient expiratory airflow limitation, wheezing, breathlessness, chest tightness, and cough, which may or may not be productive. Bronchodilator reversibility. So, if someone has asthma and we administer this medication, the lung function will increase by at least 12%. And there are triggers for asthma: viral, upper respiratory infections, allergens, occupational, smoking, exercise, stress, medications, as well as temperature. So there is cold and heat induced asthma, and it has now become a spectrum. So, and there are also some NSAIDs like aspirin and beta blockers that can cause asthma. So we use lung function testing or spirometry for diagnosis. FEV is going to be the forced expiratory volume, and the one is in 1 second. And low FEV1 implies slowing, and that is due to constricting of your airways. It is reduced in both asthma and COPD, and it is a good predictor of morbidity and mortality in COPD, which we'll hopefully touch in another session. Forced vital capacity is the total volume of air that can be expelled after a deep inhalation with no regards to time. So FEV1 is going to be a deep breath and you blow out quickly, and FVC is the entire blowout of your breath. So the ratio might not change significantly with mild asthma. It is reduced in both asthma and COPD. So in COPD, the FEV1/FVC ratio is going to be less than 0.70. All right, this picture on the left is going to show asthma and how it looks in your airways. So on the top left, it is mild asthma. Well, there may be the beginning of fibrosis and minimal mucus. And bottom left shows chronic asthma. And on the right side, it's going to show airway remodeling. This picture on the right is spirometry. We have the clip on the nose to prevent air loss. We take a deep breath and blow as hard as possible. There's a technician, or it could be a clinician as well, and you have to record the results of the spirometry test. Excuse me. You have to make sure they're sitting up. It can be affected if they're lying down. And if you have done this before or have seen it done on a patient or family member, you may be familiar with this. There are a lot of YouTube videos if you're interested. Queen, welcome. So the next slide is going to be the peak expiratory flow, or PEF. On the right, you should see the different kinds of PEF monitors. And this is if someone has asthma, they should be taught how to self-monitor, and you have to stand up straight, hold it horizontally, seal your lips, and do basically the FEV1. And if you're working with PEDS patients, you'll mention it's like blowing out a birthday candle. So read the results, repeat 2 more times, choose the highest of the 3 readings. This is known as the personal best. Okay. All right. Our next slide is going to be PEF readings, asthma exacerbation zones, and plan. The reason I have plan in caps, if you go to the bottom of the slide, there needs to be a written asthma action plan for management of an asthma flare-up, and this is to prevent an asthma exacerbation. Going back up, based on the peak flow meter reading and comparing it to the personal best, if they're within 80%, we mentioned that's the green zone. If they're in the yellow zone, they'll be 50 to 80% of the personal best, and red zone is going to be less than 50%. All right, going on to the next slide. We have the FeNO test and treatment. Nitric oxide is produced by inflamed airway cells in patients with allergic or eosinophilic asthma, and the fractional concentration of exhaled nitric oxide is to assess the degree of lung inflammation and how well the inhaled steroids are working at suppressing this inflammation. Can anyone tell me in the chat what is the mechanism of action for steroids in asthma? What is their main effect? NG Pacific, welcome. Just type it in the chat if you know what is the mechanism of action or what is the effect that steroids have in asthma. So in children and adolescents with allergic or eosinophilic asthma, pheno-guided treatment was associated with significantly lower exacerbation rate. However, no difference is seen in adults. We do not use pheno-guided treatment for general asthma population. It is for allergic or eosinophilic asthma. Getting some answers rolling in. Very good. Yes, it lowers or reduces inflammation. Steroids have an anti-inflammatory effect. Great job. All right, next we have asthma treatment goals. We're going to control symptoms, excuse me, and we're going to minimize the exacerbation risk. We also want to minimize the need for rescue inhalers. Well-controlled asthma we characterize by daytime symptoms and need for rescue inhaler, no more than twice per week, and no night waking due to asthma. If you are not familiar, our lungs bronchoconstrict uh, in the middle of the night, usually between 1 and 4 a.m. Usually patients who have asthma or an exacerbation of asthma, they will have a nighttime awakening due to already being bronchoconstricted, along with what happens overnight. So we're going to maintain near normal peak expiratory flow, and we want to keep the variability less than 20%. And all asthmatics should have a rescue inhaler and a spacer. Daily inhaled corticosteroids are recommended for asthmatics with asthma symptoms more than twice per month, or night waking more than once a month, or if they have risk factors for exacerbations. Now let's talk about some asthma meds. This presentation is consolidated. There's going to be a lot that I was not able to cover. Week has been a little busy for me, and hopefully the next time around I will beef up this presentation. So, SABA stands for short-acting beta-2 agonist, and what SABAs do is they activate adenylyl cyclase, which increases cyclic AMP and leads to bronchodilation. So, if the patient is using a combo of drugs, we're going to use beta 2 agonists first because their onset is quick. Side effects are going to be palpitations, tachycardia. We always caution in patients with cardiovascular disease, tremor, lightheadedness, nervousness, headache, nausea, hypokalemia, hyperthyroidism, and glaucoma, seizures, and increased glucose. Now I sound like one of those TV commercials where they're telling you side effects at the very end, but they do it 3 or 4 times faster. So, albuterol, levalbuterol, terbutaline, oral, and metaproterenol are short-acting beta-2 agonists. Can anyone tell me a brand name for albuterol or levalbuterol in the chat? Any brand name that you're familiar with in the chat? Also, remember in the resource section, there's a link for top 200 and 300 brands and generics. Make sure you go over those, whether you use flashcards, Quizlet, however you choose to remember them. Make sure that you're going over a little bit every time you study. It'll make the 300 seem a lot less. All right, very good. So I have ProAir, Xopenex, and Ventolin. Yeah, very, very good. Xopenex is for levalbuterol, and it's supposed to produce less beta symptoms, such as the palpitations and the lightheadedness, when used as a nebulizer. All right, very good. Next, we have corticosteroids, and ICS stands for inhaled corticosteroids. They are first-line therapy in adults and children that have persistent asthma through anti-inflammatory effects. I don't know if I don't think I cover it in this presentation, but oral corticosteroids have a role, and those are used as well. But those are used as needed during episodes. So certain inhaled corticosteroids are going to be beclomethasone, budesonide, mometasone, fluticasone, and cyclicinide. And the brand names are in parentheses. Side effects of ICS are going to be oral candidiasis, dysphonia, and cough. Dysphonia is a change in your voice. And I guess if you've seen someone inhale helium and their voice changes to something like this, that's dysphonia. So I don't know if it's as severe with ICS, but a patient may complain about a change in their voice. To prevent it, we use spacer devices, especially for meter dose inhalers. Rinse mouth after use with all steroid inhalers. Caution, strong CYP3A4 inhibitors You need to be careful with concurrent use of inhaled corticosteroids, especially fluticasone. All right, long-acting beta-2 agonists. We have salmeterol and formoterol. The mechanism of action here is going to be relaxation of airway smooth muscles and the increased cyclic AMP, which prevents bronchoconstriction. Side effects are going to be increased sympathetic, so anxiety, tachycardia, hypokalemia at high doses, and HA4 headache. Not We don't use LABA for acute asthma attacks. They're added to inhaled corticosteroids for maintenance and not to be used as solo therapy. Now, LABA have a warning. They may increase the risk of asthma-related death, and we only use this if the inhaled corticosteroid alone is not adequately controlled. Okay. All right, next we have anti-leukotrienes. And I think I flipped the O and the K. My apologies. Leukotrienes are natural potent bronchoconstrictors. We have montelukast, which is singular, zafirlukast, which is acrylate, and xyludin, which is Zyflo or ZVTLO-CR. So both montelukast and zafirlukast are leukotriene receptor antagonists, which means leukotrienes are produced, however, the receptor is blocked. Similar to histamine receptor blockers such as loratadine or fexofenadine. Does anyone know any brand names for loratadine or fexofenadine? Put that in the chat if you are familiar. Now, xylutine is a 5-lipooxygenase inhibitor, and that interferes with the synthesis of leukotriene 4, A4, C4, D4, and E4. So, counseling points for MDI. Remove the mouthpiece cover, shake MDI inhaler 10-15 seconds. And for 5 seconds. No need to shake solutions. Brand names are, oh, sorry, Alvesco or Atrovent are going to be those solutions. Prime 4 times. There's no priming needed for DPIs, which are going to be the dry powder inhalers. And hold the inhaler upright with the finger on top of the canister and the thumb on the bottom. Hash, Moreno, welcome. So take a breath and expire out fully away from the inhaler. Tighten the lips around the mouthpiece. Press while inhaling MDI deeply and slowly. Hold the breath for 5 to 10 seconds. Wait 1 minute before repeating, and clean weekly. Rinse mouth after use. All right, so yellow zone management. If you recall from the earlier slides, this is when you do the peak flow and it is 50 to 80% of your personal best. So first we're going to have the preferred treatment is going to be low dose ICS and formoterol, and then the alternative is low dose ICS with SABA. 2, will assess the symptoms after 1 hour. If green zone, continue the long-acting and ICS combo for 7 to 10 days. If if yellow, we'll add a short course of oral steroid, aka prednisone. Red zone management is going to be if the peak flow meter reports less than 50% of the personal best. And so we're going to do similar low dose ICS and formoterol as a rescue inhaler instead of SABA alone. and start oral steroids. Remember, they take hours to work, and go to ER or call 911. For both intermittent, and just a note in the ER can also do IV steroids. For both intermittent and mild persistent asthma, the GINA guidelines recommend low dose ICS plus formoterol like Symbicort, and an alternative is going to be low dose ICS taken with SABA. What is GINA, you ask? GINA is going to be the global initiative for asthma management, and we'll cover that in a future slide. So, asthma management in the emergency department, we're going to do SABA, which is albuterol or levoalbuterol via nebulizer. Systemic steroids, there you go, oral or IV, oxygen. And if severe, we can add ipratropium. Could anyone tell me what type of drug that is? And for those of you that answered Claritin and Allegra, very good. In the chat, if I can get a type of what category ipratropium is in. You can do IV mag sulfate, Heliox, which is a combination of helium and oxygen, has better penetration. Now, if bronchoconstriction is severe and the patient is not ventilating, you can do intubation. All right. Getting different answers for ipratropium. I have some say that it's a short-acting muscarinic, and I have some that say it is a long-acting muscarinic. So let us see. All right. So let me first answer the question of ipratropium. We have another vote for short-acting. All right. It is a short-acting muscarinic antagonist. It is anticholinergic. There are llamas that are on the market. Can anyone put any generics for the llamas into the chat? There are some newer agents as well that have been tested. Good RPAT with the newer one. And yes, tiotropium is long acting. Very good. So I comes first, that's going to be short acting, and T comes later, that's going to be long acting. And RPAT, good job. Umeclidinium is a long acting. Now, that's going to be the slides that I have, and we're going to do 4 practice questions. For the newcomers, what I do is I'm going to read the question, and then at the end, you can put your answers in the chat. If you're not sure, you can put a question mark, and if you would like to take a guess. And then at the end of the 4 questions, I think I have 4 today, I'd be happy to answer any questions or concerns you have about this topic, the Naplex or the MPJE in general. So practice question 1. Can everyone see it on the screen? Can you see practice question 1? Can I just get a yes in the chat? Good, thank you. Thank you, Nikki. A 33-year-old male with a history of asthma was recently started on an albuterol inhaler. Which of the following would be an important education point? Choice A, rinse mouth with water and spit following administration to prevent thrush. This medication may interact with over-the-counter antitussives like Robitussin. Choice C, this medication may cause a short-term increase in heart rate. Choice D, this medication should not be used in patients with a history of GERD. All right, getting some answers coming in. All right, so choice C is correct. Can cause palpitations and tachycardia along with a feeling of nervousness. So choice A is going to be more for inhaled corticosteroids like budesonide and fluticasone, and choice B and D are outliers and distractors. Did anyone have any questions or concerns about practice question 1? All right, very good. Let's go to practice question 2. What is a methacholine challenge used to help diagnose? A. Parkinson's, B. Asthma, C. Multiple sclerosis, D. Diabetes. All right, getting some answers coming in. Yes, good. The answer is B. Methacholine is a cholinergic agonist which causes the airways to close up, making it difficult for patients with asthma to breathe. And so remember that inhaled anticholinergics like ipratropium, which is short acting, and tiotropium, which is long acting, help open up the airways. All right, good job, everyone. Good job so far. Let's go to practice question 3. A 51-year-old female with past medical history of hypothyroidism, asthma, and hypertension presents to her primary care with a complaint of persistent shortness of breath. She has increased use of her short-acting albuterol metered dose inhaler to twice daily in response to shortness of breath which has persisted over the last month, not related to infectious illness. She also takes fluticasone, propionate, 110 micrograms, 2 puffs BID. She also currently takes levothyroxine 100 micrograms orally daily and lisinopril 20 mg daily. Vital and labs are within normal limits. Her provider wishes to initiate a combination long-acting beta agonist with inhaled corticosteroid combination in one inhaler discus. Which of the following contains both of these medications? Select all that apply. So just a quick note, select all that can apply can be one answer, all the answers, or anything in between. I think both RxPrep and Past Naplex now do a great job in not setting patterns. All right, we're getting some answer choices. Fiven said, welcome to the session. We're on practice question 3 of 4. Anyone else want to either guess or put your answer choice in? All right. So we have the correct answers are going to be A, B, C, and D. And so if you chose those or any of those, great job. So choice A is going to be Symbicort, and this contains budesonide and formoterol. Brio ellipta contains fluticasone furoate and bilanterol. Dulera contains mometasone and formoterol. And Advair HFA contains fluticasone propionate and salmeterol. Now, choice E, Arnuity ellipta, only contains fluticasone furoate, making choice E correct. Incorrect, sorry. There are a lot of ellipta formulations, and so remembering them, memorizing them are important. Inhalers that are both, sorry, ICS combos are very, very high yield for the Naplex, so make sure that you go over them. All right. So, does anyone have any questions or concerns for practice question 3 so far? All right. And if you come up with a question later, just put it in the chat or send me a DM. Practice question 4. BL is an 18-year-old female who presents to your clinic today with some concerns regarding her asthma. She says she was diagnosed with asthma as a child, but her symptoms seem to be worsening lately. She has experienced increased wheezing and shortness of breath, as well as chest tightening and cough. She denies sputum in her cough and reports no recent fevers. She says that she recently moved to a new house, and since then her allergies have been worse than ever before. In the past 4 weeks, she has had symptoms most days of the week and has experienced nighttime awakenings with asthma at least once a week. She feels it has now started to limit her daily activity and she can't exercise like she used to. The only medication she takes for her asthma is an albuterol inhaler, which she says she relies on pretty much every day. She is not having an acute exacerbation at this time. Past medical history is going to be anxiety, depression, allergic rhinitis, and asthma. Social history denies tobacco use. Medications are going to be sertraline 100 mg orally QD, albuterol 90 microgram actuation MDI, citrazine 10 milligrams POQD, fluticasone nasal spray, and once daily. Pertinent labs, blood pressure is 119/80, heart rate is 68, respiratory rate is 17, weight 140, height 5'5". Spirometry shows FEV1 at baseline 69%, and after albuterol 400 micrograms, it's 85%. The ratio is going to be 0.74. Which of the following low dose inhaled corticosteroids plus LABA would be best to initiate for long-term control? So, choice A is Symbicort. Choice B is Advair Discus. Choice C is Adbrio ellipta. Choice D is Adalera. Choice E is Trilogy ellipta. And choice F is no addition at this time. And I would just like to counsel you that the Naplex likes to put the correct brand name but the wrong dosage or the wrong formulation. So make sure that whatever answer choice you choose, the brand name, the dosage, and the dosing are all correct. And if you've already answered and you're reconsidering, feel free to change. Both practice questions 3 and 4 touch on area competencies 1, 2, and 3. Area 1 of the Naplex being obtain, interpret, or assess data, medical, or patient information. Area 2 is going to be identifying drug characteristics, and Area 3 is going to be developing or managing treatment plans. Getting some answers. Getting some answers. So remember, knowing the dosing and potency is important for corticosteroids and being familiar with the various asthma medications, including brand and generic, are important for the Naplex as well as your clinical practice later on. So the correct answer here is going to be B as in boy. Adding Advair discus, which is fluticasone, propionate, and salmeterol, is going to be the correct choice. Let's talk about why. We're looking for a low dose ICS plus LABA combo, and although answer choice A is the correct inhaler, it's written for QD and it needs to be 2 puffs BID. So remember what I said about all parts of the question needing to be correct? You have to make sure. So that's why choice A is incorrect. Choice C is incorrect because Brio ellipta does have ICS and the LABA. The dosing is wrong. This is the dosing for Symbicort, which at a medium dose. All right, so tricky, tricky. Choice D would be acceptable, but once again, 200 micrograms and 5 micrograms is going to be a medium dose. And choice E, Trelegy ellipta, is not only ICS and LABA, it's also a LAMA, which is a long-acting muscarinic antagonist, umaclidinium. So that's why choice E is not correct at this time. Answer choice F is also incorrect because the question is asking what can we add to initiate long-term control. So good job for those of you. Sapphire, if you guessed B, good job. And if you didn't, please make a note to go back and review. So that is the end. There is a survey. I ask that you fill it out. It helps us improve. And if anyone has any questions or concerns at this time, you can put them into the chat, or once again, you can send me a direct message. Remember, you are all on this journey. Put in the hard work, you will get the result that you are looking for. Make sure Suspicious Bunch is put together, as well as PharmaTurtle's a bunch of great resources. Make sure you use them. And as always, have a good evening. Take care, everyone.